We'll get started with our meeting tonight. I want to thank everybody for joining us on the conference call, the Zoom call here, talking with Dr. Kaiser, our public health officer. Before we get going, I just want to once again thank Dr. Kaiser for his leadership and foresight in fighting this coronavirus pandemic. I know I feel safer and my family feels safer. And once again, thank you for the leadership. Just a few housekeeping rules. Dr. Kaiser is going to give us an update. We'll go through the 12 questions. If there are additional questions, please put it in the chat box at the very bottom. And if time permits, we will go through those additional questions, but that's if time permits. We have 12 questions that have been submitted ahead of time. And without any further delay, Dr. Kaiser, the stage is yours.
Thanks, Dr. Holmblad. First, the statistics. If you aren't already aware, the county does update our statistics daily on the department website. That address is rivcoph.org/coronavirus. That's rivcoph.org/coronavirus. Today, we've reported 2,264 positive cases out of at least 29,571 tests completed. I say at least because we are almost certainly not capturing all the tests which are ordered. Our internal estimate is almost 32,000, meaning more than 1 out of every 100 county residents has been tested so far. We recorded 59 deaths today, 5 more in today's count. 207 of those cases are hospitalized, with 70 in the ICU, and 472 individuals have been officially cleared by the department. The pediatricians and family practitioners will note we continue to have a huge hole in the under 18 age range. Very few cases have been recorded in that group. There's a lot of speculation about why that is. Nevertheless, that national trend is borne out here locally. 103 cases have also been detected in our jails. If you look at the statewide picture, we are second in the state in cases, second only to Los Angeles. But I also want to point out that we are probably second only to Los Angeles in terms of the number of tests we've been able to run. And I've been trying to work with the state to make sure that people get a clear idea of exactly how much testing is occurring in various jurisdictions, because that tends to vary widely. Also, our doubling rate is variously reported as between 7 and 8 days. Again, that's also higher than many. But remember, this needs to be understood in terms of how rapid we're able to do case finding. We are still running 4 locations throughout the county for testing, as well as, of course, everything that the various private providers are running. And we are deploying our rapid response teams to the skilled nursing facilities and long-term care facilities to ensure that we keep those stood up. And in fact, this might be a good time just to transition into the questions, because one of the questions specifically addresses that. So Dr. Holmblad, I'll put it back to you for that.
Okay, thank you very much, Dr. Kaiser. Question number 1, it appears the curve is bending in California. Is that true for Riverside County also? And what can we expect in the next 1 to 3 weeks?
The answer to that one is generally yes. The LA Times actually has a very nice coronavirus tracker, which you can look at. It's linked off of the main page. It's in that bar to the right. And you'll see the various curves for the individual counties. Now, again, this is not normalized to the number of tests that they are doing, which tends to make us look bad because, frankly, there's more cases to find and we're finding them. But in general, if you look at our trend as well, you'll find that our doubling time is also lengthening. And depending on who's doing the calculation, whether they use a rolling average or a 3-day average, it varies somewhere between 7 and 8 days. I think that it's important to point out, though, that if you've got a doubling time like that, it's still increasing. We have not yet reached a plateau. And in addition, and I'll say more about this a little bit later, we're also discussing how we might get asymptomatic individuals tested to get a more realistic estimate of our prevalence. It's, even though it was initially very controversial whether asymptomatic individuals could carry the disease, I think we've seen enough evidence to suggest that, at least for some measure of it, their symptoms are either so minor or so clinically inapparent that they might as well be asymptomatic. To our knowledge, only Los Angeles County is doing that. We would like to do something for that soon. I think within the next 1 to 3 weeks, though, overall, people probably should not expect much change. And there's a question specifically addresses this at the statewide level, but just to give you a preview of that answer, whatever I do locally, I can always do more than what the state is doing in terms of how restrictive I am, but I can't do less. And the governor still has an order in effect, and one of the questions specifically addresses that, and I'll get into more on that particular one.
Okay. Question number 2. In your opinion, are hospitals, nursing homes, and other facilities ready for the surge? What more should be done?
Honestly, the hospital surge that was predicted really wasn't. I'm sure those of you in EDs can confirm that emergency department and EMS traffic volume has really been down precipitously. The usual frequent flyers and the people without PCPs who go there for routine care are essentially staying away in droves. We certainly do have people on vents and we do have them in ICUs, but hospital capacity has not been exhausted. In fact, general hospital census across the board are well below normal. I think Bruce mentioned today's was about 53%.
Yes.
Yeah, he's nodding, which is unheard of. I know that there are some hospitals that have such a low census and such a low patient volume, they've even decided to do some limited elective procedures to try and get throughput. There is some question, though, about what the governor's strategy might mean for hospitals going forward that was sort of obliquely addressed on the statewide call today. There's the term herd immunity gets thrown around a lot these days. It's probably premature given that we don't know how protective the antibodies are. We don't know how long-term they will be protective, even if they are. And certainly if we get to a situation where we're beginning to rely on that, then that has some real implications on how many people get infected. Some of those people will, of course, have serious medical complications, and those people then would in turn would affect the hospitals. I don't know what that actually means as far as a long-term surge, but it's certainly something to be aware of. But where the surge came this time around and where we probably weren't expecting it initially was in the subacute setting. And certainly some of our skilled nurse facilities and LTCFs were ready, but candidly many weren't. And we found out the hard way with Magnolia Rehab. My folks who are living up in South Dakota even heard about that on the news. But there are lots of other ones which aren't as high profile, and we still have issues with absenteeism at various other facilities. We haven't had to evacuate an entire facility, but we have had to move some patients around. The SNF outreach and support team and the quick response teams are the county mechanisms for getting testing done fast when we identify a case in one of these high-risk settings. And then we try to get there as quickly as possible, make sure the staff are educated with safety techniques, assessing and or supplementing the protective equipment, because what we really want to avoid happening, and unfortunately what did happen during the Magnolia Rehab evacuation, was to end up with these people moving into acute care facilities. We really want to try to avoid that unless there is some medical indication to do so. We visited just 16 facilities just today, covering a variety of levels from SNFs to assisted living. Fortunately, we have been able to head off some additional sites going under. We are, for those physicians who do have patients at Magnolia Rehab, we are discussing the eventual fate of that facility with the state this week. It is currently under my commandeer order, which is itself an unusual event. We're talking to the facility about what's going to happen, and eventually will occur at that at the end. But the long and short of it is that I think is where we're going to have to continue doing ongoing efforts. And for those of you who do have patients in those situations, that will of course affect their care, and we want to make sure that we do so in cooperation with the physicians who are taking care of them in that setting.
Okay, question number 3. San Bernardino testing has become so restricted that it is virtually unavailable. Now only in Victorville for 1 to 2 hours, and internet forms needed to be filling out. What is Riverside doing differently to make testing more available?
I'll go ahead and say I'm very proud of our testing volume. I think we may even be doing as much as Los Angeles County, and certainly in terms of tests per million. The secret sauce has turned out to be volume arrangements with the labs. It's really just that simple. We make the money, so they give us lots of collection kits, and we use them all up. It took us a while to get there too, and I know this has been a problem for some of the smaller operations because, LabCorp doesn't want to just give you or Quest doesn't want to just give you collection kits if they don't think you're going to use them, because that's money out of pocket for them. And it took us a while to build it up to the point where they know we're going to go through that number. And we're trying to keep that volume as high as possible to keep our capacity as high as possible. This in large part, I think, explains why we have roughly double the numbers of cases of San Bernardino with only a marginally larger population. That county line is really just artificial. We're serving much the same population in both places. So there is no reason why the case number shouldn't be the same between both counties, except for the fact that we're doing double the testing, ergo we have double the cases. In fact, we have a little bit of slack right now, which is why we're looking to expand to asymptomatic individuals. Number one, we want to keep that volume up so that we're able to respond and maintain that nationwide capacity. And one of the questions addresses that, and I won't go into it here. But we'll want to make sure that we can continue that throughput, and that has been problematic for some of the smaller setups. We will have an announcement on how we'll do that very soon, but I'll just say as a preview, please remember people will still need an appointment. We still do have daily caps. Do not send them over on walk-up because we won't be able to facilitate them. I'll talk more about that on a later question.
Okay, thank you. Question number 4, how do we help our patients get back to work that have tested positive for COVID-19 and they have isolated 14 days and they have no more symptoms and they can't get retested because there are not enough tests? They're wanting a letter from us to get back to work. Please advise.
Well, the clearance question I know also came up in the later one, and I'll talk about it briefly there. I mean, we're not generally recommending, at least not right now, people get tested, but because we'll be able to do asymptomatic testing, that may be able to help meet the need for some of those people. Again, don't just send them over. They'll still need an appointment when we get that up. But I think it should at least address it for those situations where the employer won't take them back without a test once we get it running. I should say for the record that I did speak to county council about that, because that was a real question early on, and it looks like it's an ongoing problem of people who are now unable to get work clearance because their employer won't take them back without a negative test. There's reason to believe that probably is against labor laws. I don't know the full details of it, and it's probably something that would need to occur at the federal level. Nevertheless, I mean, that still doesn't really help the docs who are in the position of a patient who's desperate to get back to work and can't, and hopefully that'll at least be a relief valve for some of those situations.
Okay, thank you. Question number 5, is antibody testing available in local labs now? How will we find out if we could start widespread RNA testing for patients who have mild symptoms or patients exposed to COVID-19 but are asymptomatic?
For antibody testing, we have not yet heard of any labs that are doing it specifically. In fact, if you look at the FDA's emergency use authorization list, they have EUAs only for 3 serology tests. 2 of them are cartridge based, and I don't know of any lab that's running any of them right now, although I'm sure some eventually will. It is something that I imagine we will consider at the county at some point, but we don't, again, like I said, we don't know what level of immunity they confer. We don't know how long lasting it is. At least for the time being, I consider it speculative from the perspective of case finding. We'd probably still be relying on PCR, at least from our level. I do know of some facilities which are planning, and I say planning because they haven't been able to get it yet. But I do know of some facilities which are planning to do a hybrid approach where they would do antibody testing for somebody who'd been sick for a minimum period of time. Usually you look at the data sheets for them and they want at least 10 days into the disease before you get maximal sensitivity out of those tests. So for somebody who doesn't hit whatever that magic number is for the test that they happen to be running, then they would probably run PCR up until that point and then go from there. As far as the widespread RNA testing, frankly, if you want to test asymptomatic people right now and you have the ability to collect and send tests, go right ahead. Somebody in the chat box had asked about PPE requirements. Officially, the CDC still does recommend for somebody that is a suspect, you should still be preferentially using N95 masks. For some people that you don't need negative pressure, but you may still want to be using that for that circumstance. For those facilities that are able to do so, and some of the larger ones are, because we know that we're getting negative and positive tests from them, then go right ahead. There is no restriction on that from us. In fact, some urgent cares have even started doing exactly that. One of them was in downtown Riverside, not too far away from the RCMA offices. That occurred yesterday. We got a whole bunch of phone calls because they put a large banner out and some people thought it was a scam. It turned out they were on the level. We actually had a secret shopper go through them and collect some information. And then I called over there myself to check what they were doing. And they are a legitimate urgent care that just happened to be in their new operation. If you want to send asymptomatic people desiring testing to the county, though, then stay tuned for the next day or so, and we should have more information about that.
Okay, thank you. Question number 6. When do we expect to lift social distancing in Riverside County and statewide? Are we coordinating this with the state?
I alluded to this earlier, but since this is the answer I was waiting on to make it more explicit, we have to coordinate it with the state. The state order takes precedence over any local health officer order. I can always take a stricter position with respect to the local emergency in effect, but I cannot take a looser one. The governor certainly has talked in his noon briefings about making sure that there's appropriate local control. I know that the Board of Supervisors is very interested in that, and they've made several public signals to that effect. And it is true that we do have input into the matter, not only through the elected officials, but obviously this is being done through CDPH primarily, and the state health officer and I talk about this on a regular basis. And I know that Kim Sarwatari, our director, also speaks with her counterparts in other jurisdictions and also directly to the state. But ultimately, as terms of the practical matter of how this gets loosened up when it does, the governor's stay-at-home order is still in effect, and it has no sunset date no matter what I do locally. Even if I were to tear up my orders or to make no further orders after April 30th, which is when my gathering order expires, the governor's order may still be in effect. And as I mentioned, we had some rather loud public signals, particularly from Los Angeles County and some other jurisdictions. I don't think they're going to be let up even as late as May 15th. I'd say that I wouldn't expect anything to happen in the month of April. If there's going to be any motion on that front, it's probably not going to happen until sometime around early or mid-May.
Okay, thank you. Question number 7, will the County Medical Association and Riverside County Public Health strongly advise Governor Newsom against reopening the state until we have testing, contact tracing, as well as other protections for the people of California?
I'll defer to Dolores on the RCMA bit, but
Okay.
I'll give the county's position. The position I've advised to the Board of Supervisors, frankly, is exactly that. The governor has done his 6-bucket speech, and I won't belabor the point. They're easily available online. But we have, as far as the metrics which he's talked about, he's broadly gone into the similar framework that you've seen out of some of the white papers, such as the American Enterprise Institute, and I think Brookings had one. You need to make sure that, number one, you have an adequate understanding of the problem itself. Do you have enough people tested so that they become a representative sample? Do you have the ability to do ongoing case finding? And when you do you have the ability to respond to it quickly? We have over 1% of our population tested to date, and I mentioned that number, at least 29,000 tests officially, but our internal estimate is as high as 32,000. And that's combined, of course, between public and private testing. And that the Surgeon General a few days ago made a recommendation of somewhere between 1 to 100 to 1 to 50 testing, and that gets us well within range of those suggested minimum population testing numbers. But both the president's and the governor's strategies have noted that we need ongoing surveillance capability, and it needs to be added on, frankly, not bled off. We've gotten a number of requests from very well-meaning groups that want to do additional testing, but when we've actually sat down and tried to talk about how this would be operationalized, they want the county to provide them supplies, lab capacity, etc., and it's not clear that these operations would be self-sustaining. Their enthusiasm is totally appreciated. We really need that there to make it happen, but this is not adding capacity. At best, it's just moving it around. The long-term ability to sample the population will be enhanced by us having partners that can add to the capacity, and we need more of them. Between our 4 sites, our capacity is somewhere in the ballpark of 2,200 odd tests per day. But if you look at the national estimates, AEI says about 500,000 to 1 million from Harvard for daily estimates. we need to have a capacity of roughly double that 2,200, maybe as high as 6,000 to 8,000 if we're going to get any closer to those number of national estimates normalized to population.
All right, thank you. Question number 8. Please clarify COVID-19 period of contagiousness. How long to exclude from school, daycare, or from work? This is to help providers give patients clearance letters of contagiousness so patients can return to school, daycare, work.
This is the question I was waiting for earlier on. If at all possible, we would prefer clearance to come from us, at least for right now, for a couple reasons. Number one, this gives us better tracking of statistics. And as far as the speed of it, we have an entire army of people manning phones on the 10th floor in the County Administration Center working down the day's cases. In fact, we keep adding to that number. We're now expanding out into hallways and other rooms to get enough phone banks on for this. The reason why we want to do that is, number one, we want to make sure that we're using consistent guidelines, especially for people who are healthcare workers. We don't want people returning to work too soon and thereby becoming an additional problem. And we also want to make sure we have good tabs on what our recovered number is, because that's also important for when we do those kinds of population surveys. You know, again, herd immunity gets thrown around a lot as an estimate. But it's going to be, let's assume that there is some long-lasting immunity, or at least long enough to make a difference. And even that is not necessarily clear given what we've seen with some other coronaviruses. Let's say that's the case. We're going to really need that number. Nevertheless, in general, just so people understand the process, we are using modified CDC non-test criteria. The modification that we've done against theirs is 7 days since symptom onset, and then 72 hours of being afebrile, and then substantial improvement or resolution in respiratory symptoms. The modification that we have done is I'm going 7 days from the positive test rather than onset of symptoms. That gives me a little bit of wiggle room. We are only using the CDC test criteria only where we believe the individual is unreliable. That has happened in a couple of instances, which I won't go into detail, but nevertheless, by and large, we are trying to clear these people by clinical criteria. If you get a positive test, report it to us anyway on a CMR. Some of you have asked what that fax number is, so I'll go ahead and repeat it on this call. If you send a CMR to our regular number, the 951-358-5107, it'll get there, but it'll be delayed. And we would like people to use this dedicated fax line for COVID-19 positive CMRs only. That number is 951-436-7776, and I'll repeat it, 951-436-7776. Once that gets to us, that gets in the hopper, and then we refer to them when we track it down. We have people calling, making sure that patients are aware of what requirements are there. If letters need to be issued, we can help them. And if you want to know what to do on that, certainly give our disease control numbers a call, and we can also help to advise you on that. But for clearance purposes, please let that come from us, at least for the time being, so that way we know who's getting cleared, we know how they're getting cleared, and then we can keep that running tally so we have a better surveillance of how many people are recovering in the population.
Okay, thank you. Question number 9. Understanding the policing of facial coverings is not easy, yet there is a significant number of people on the roads and other public open spaces jogging or cycling or walking without coverings. As it stands today, information shows that aerosolized virus can be in the air at least for 90 minutes. It would be useful to know, since the facial covering order, how many citations and fines issued by geography, and hopefully that can be published in the local media, would be a deterrent to some extent. We are in a crucial phase here in Riverside County today and must ensure such measures are solidified. Obviously, this will help, among other things, to avoid secondary peaks. Comment, I guess.
This is clearly an enforcement question. I can't speak for the sheriff or the city police departments on that. Technically, the health officer is, I am a law enforcement officer, and I can cite, and my ticket book is somewhere within Michael Ozier's desk, I'm told. But as a practical matter, the enforcement is going to lie with sworn peace officers. I know our sheriff has made some public signals on that. I will not speak for him on this. Certainly, we would want people to adhere to the order as much as possible because, frankly, I think that number one reiterates to people that they do need to maintain social distancing. It's something to remind you there's a reason you're wearing a face covering or a mask right now, and it's not because the situation is normal, and it's not because it's a fashion accessory. But the enforcement question, unfortunately, is going to lie with law enforcement, and I can't really speak for them.
Okay, thank you. Question number 10. What is the current status of PCR testing as to supply and demand and the roadblocks which exist still? Any word on post-convalescent serology testing? What about the Abbott ID COVID-19 testing sites and capabilities? The plan for acquiring the Rutgers saliva test? And D, any insight into the false negative PCRs? It is somewhat dependent on the stage of the disease, as the virus load is fairly brief in the nasopharynx.
The PCR testing, again, like I say, part of our secret sauce is because we run the tests in such volume that we've been able to get it through the commercial labs. And their backlog is now running about 2 to 3 days, which has gotten a lot better than it used to. Part A on serology testing, I've answered, but let me hit some of the others. The Abbott devices in particular, they've gotten a lot of press. I think many of you remember when President Trump plunked one down on the desk during one of his briefings. But as far as actually getting your hands on one, it's been extremely hard. The state managed to get a number of them, and I had a discussion with the assistant public health officer, and we have managed to allocate 2. One for the West and one for the East, but it's not just a matter of getting the devices, much as the issue that we had with PCR testing earlier on, it's the test kits. The Eastern hospital we're working with, and I'm not going to name it until we actually have them up and running because I don't want them getting phone calls. They made an initial order of 70 test boxes, which is not an excessive amount. I think that's on the order of a few hundred tests, which in the numbers that we're actually running cumulative is really not that many. We were told by the state we could order 5, and we haven't even gotten that. So it's going to be a while before those systems get up and running, even though we actually have the machines now. Again, for us, it's going to be lots of swabs down people's nostrils for a while to come until we can actually get some of these online. I'd also like to mention that test does seem to have a lower sensitivity than the CDC's RT-PCR, which we are running. In fact, as a whole, the rapid PCR ones seem to have that problem. I don't know why. Our clinical lab director has some ideas on that, but they're really just speculation. The Rutgers saliva test also got a lot of press. It's certainly a lot easier test to acquire than jamming NP swabs down people's noses. But currently it is not yet publicly available from any distributor that we are able to find. We are watching that closely, but we expect that it will probably be at least as impacted as any of the other tests. Now, as far as the false negatives go, it's certainly a phenomenon we have also observed. I haven't heard a consistent explanation onto why they pop negative. I'm sure that inadequate sample acquisition accounts for at least some of it, but PCR as a whole, especially the lab run, that is pretty sensitive as a test. So I don't think it accounts for all of it. Again, like I say, some of the rapid PCR tests have lower sensitivity. Do keep in mind, for those of you interested in serology, that those tests tend to be lower still. Of the serial testing we have done, and we haven't done much of it, we've been trying to do case finding and to reserve our testing capacity for finding cases and usually clearing people by clinical test criteria. We have done some serial testing for individuals we have found unreliable, and we have noticed that phenomenon. In fact, I got a report on that just the other day, so I don't have a good answer for you. I think that's a major reason why you need to have those 2 tests 24 hours apart. But just keep in mind that these people are going to end up shedding junk RNA for weeks. We saw that with Ebola, for example, and that's why we're trying to use clinical criteria if at all possible.
Thank you. Question 11, are there additional ways the RCMA and physicians in the community can assist?
I think really the big way is just whatever can be done to contribute to case finding. It's that not only that current capacity, but the ongoing capacity that we require. I mean, we need to fully define the problem before we can say we're dealing with it. and we're going to need ongoing surveillance to respond if things go in the wrong direction. Also, prompt reporting, which everybody's doing and we appreciate, including also a denominator if you can, not just how many positives you get and the specific positive themselves, but if there's some way of getting the denominator, especially if you're one of those group practices that may not be mentioning this data, is also good for knowing how we're doing. We do get some feeds from the labs. In fact, I issued an order to that effect, and most of them are at least reporting that into into the county directly. But we'd like to try and shore this up through Manifest MedX as well, because I think that they could be a very valuable partner in this kind of surveillance, not only here, but also in the future. And we want to encourage people to make sure that they report that denominator to them as well as the order requires.
Thank you. Question number 12. Are the commercial health plans in California required by a governor's order to accept claims for telemedicine visits using the 992 series codes rather than the much lower reimbursed telephone codes? Providing there is appropriate documentation, what codes can be used for new patients and follow-ups? And do we have to use a GT modifier, then use the 99442 and 99443 codes, which have dramatically reduced reimbursement?
I think that sounds like a Mitzi question.
Okay.
I'll defer that one to the billing experts, but I can certainly mention this deficiency to our DHCS contacts as a gap.
All right. Thank you very much for answering. We do have, if you have time, I know on the chat, Dolores just sent me something over here. There have been reports of some physicians signing off on work orders for up to 3 months for healthcare workers or support workers. How can RCMA help with this?
Yeah, I've heard that too. I mean, ultimately, if there's a the enforcement mechanism probably can't come from me, because we'd have to audit every single chart and determine, there may be actually a reason why they need to be off for 3 months that I just don't know about. I am concerned about it though, because it does affect the workforce. Certainly the governor was concerned enough to issue the executive order, which allows healthcare workers on quarantine, not symptomatic ones, but healthcare workers on quarantine to be able to still work with a face mask. And of course, everybody nowadays has to wear face coverings anyway. We're trying to message as much as we can from the health department side, but again, ultimately, that's probably not something I could operationalize very well as an order because of the myriad of reasons that could be for it. I think that something like a best practice guideline could be very helpful. I know that it's something that's been reported to me, and something that we're trying to watch for as much as we can and try to encourage people not to do that if the reason is simply because they're concerned about COVID-19.
Okay. Thank you very much,
Sure.
Dr. Kaiser. Dolores, I can't get to the chat portion on my computer here. Were there any other questions that came up?
Dr. Kaiser, if you have maybe 5 more minutes, I can, I think some of these will be fairly quick for you.
Okay, I'll hang on for a couple minutes.
Okay.
Thank you, Dr. Kaiser.
Okay. What precautions to take for start doing office diagnostic testing?
Long and short of it is, if you're dealing with a suspect, the CDC guidelines are still preferentially to use an N95 mask and appropriate PPE. For most individuals, this will mean a face shield, which could be one that you can clean. It would mean an N95 mask if you've got them. You could use a surgical mask, but N95 is preferred still in the current guidance. And then some sort of barrier gown and gloves. They do not anymore need to be done in negative pressure. If you're concerned about it, you could certainly do it outdoors if you have that capacity, but that would be the recommended requirement for PPE if you're going to be collecting it from a nasopharyngeal specimen. Obviously, if you plan to use one of the serology tests and you're actually able to collect, then it's just a blood draw or a finger stick.
Okay. Is Riverside going to allow hospitals to return to normal business with elective care as long as we have adequate PPE?
We haven't really ordered people not to do electives. We have strongly suggested it, though. Yeah, as long as the facilities have adequate PPE and also adequate bed space, and certainly it is the case now that the hospitals do have adequate bed space. I mean, we want to make sure that the bottom line is still met. And I know that our RUHS Medical Center is considering doing some limited elective procedures. They'll probably take the higher priority ones, but they've got space in the PACU and they've got space in their ICU, and they think they can do it. If your facility feels that it's got this capacity for it, there's no need to get permission from us. Just keep in mind that situations change relatively rapidly, so keep an eye on those numbers.
Okay, I'm going to combine these two questions, and I think this will be our last. Will serology testing be needed in large amounts to get a better idea of the epidemiology of COVID and make better preparation if we have subsequent waves in the coming months and years? And how accurate and available is the serology testing?
As I mentioned previously, there are exactly 3 tests in the FDA EUA list for serology testing, and 2 of those are what they call cartridge ones, which is to say, you know, it's like any other kind of office a dip test, pregnancy test, things like that. The other one is actually a blood draw assay. It will certainly be needed, but again, like I say, the question is how predictive is immunity against COVID-19. If you've looked at some of the other coronaviruses, it hasn't been all that great. SARS would be a great example, but also the 4 common strains which circulate in our population to this day, of which COVID-19 has a great chance of becoming number 5. And we haven't seen that the immunity to these people has been really all that long lasting. It may give us an idea of the actual prevalence in the population, but again, you're probably doing it after the fact, because as far as the accuracy goes, the sensitivity of these tests, particularly for people in the acute phase, tends to be fairly low. Even though the combined IgG, IgM ones, I've been seeing sensitivities on some of these as low as 80%. Now they rise up to about 90 to 95% by around day 10. But still, that's not all that great, and you'd have to sit around for a long period of time to do it, which is why we've seen a hybrid strategy in some places who have been prepared to test, where they'll do a swab for somebody who hasn't been sick all that long, usually between the days 1 and 10 of illness, and then after day 10, then they'll move to the serology one to try and get a better idea of any antibodies they might have on board. So I think that it has a potential purpose, but I think that purpose, at least from the public health department's perspective, is largely speculative. If I'm going to be trying to find cases, I need to find them fast, which means I need to be running a test which has as high sensitivity as I can get my hands on, and at least for the time being, that's still going to be RT-PCR.
Thank you, Dr. Kaiser. Thank you for your time once again, and we look forward to our next briefing in a couple of weeks here.
Well, like I say, I appreciate the format because I think that gets the most questions answered, and in the period we have available. We're still running things down here in the county EOC. I'm still at the county building, and we're still running on weekends as well. Yeah, we really appreciate the efficiency of the format for getting information out in as dense a package as possible.
Okay. Thank you once again.
Take care.